on day-to-day basis life and in general OPD and ICU. To say thanks, Dr. Ajay, Dr. Raghavin, and all of you who have joined us time in your busy schedule. Dr. Ajay is plastic surgeon in super specialty hospital at Riva. Now I would like to request you kindly brief about yourself, bit about yourself to our audience. Thank you.
Everyone, good afternoon. Myself, Dr. Ajay Pathak. I'm Assistant Professor Plastic Surgeon, Riva Medical College, and clinical practitioner also. Uh, uh, Today, regarding it's a genosensor. It's really an innovative approach to detect the antimicrobial infection and antimicrobial drug resistance also within golden period time. So I think it would be beneficial for patient and for critically ill patient also. Can any queries, any questions regarding this?
Any questions? Anyone is having any questions would like to ask Dr. Ajay, or we just start our Q&A round in between. So today's theme is: are we really treating the infection casually, or should be more attentive while treating ill patients and the correct antibiotics at correct time? So my most of the questions would be related to this theme. So here on, I would like to start. Question to
Yes.
you, Dr. Ajay. Can you please
Yeah.
this type of infection you frequently encounter in the clinical practice?
As plastic surgeon, I also looked in burn ward. And diabetic foot patient. These are commonly infected patient we have encountered. Okay, so the common in burn after 4 5 days there is chances of sepsis. There is the wound infection, UTI. There is the catheter based infection and in other patients like diabetic foot, there is the also infection, osteomyelitis and all. Apart from this, our patient have post-operative wound sepsis, suture site infection, discharge. These are common infection we
Frequently you observe these infection in your patients after admission.
setting. We admitted fit patient. Generally, these have no symptom. Apart from those post-operative patient, we on third or fourth day, you sometime we observe there is the clinical symptom of fever. There is the some wound discharge, some initially serious. After that, after a week, there is the first purulent discharge. So these kind of usual wound site infection we encountered.
Okay. So I would like to know, like there are settings like in the corporate hospitals, they do send the regular patients culture for the just after admission. So what is your practice? You do not send it on the admission. You how you apply how you send the culture test for infection after having symptoms or just after admission. What is your practice?
In our practice, usually we observe the symptom. Initially, we send the CBC, blood test only. So we can follow the trends of its WBC, neutrophils and all. If they are normal, and then we look for symptoms also like fever, discharge, other symptoms, and other parameters like other parameters we clinical parameters we observe, and if required then we'll send culture after 4 or 5 days in our setup.
So what are the
Yeah.
general methods you are using for the infection detection?
uh, Journal method, we are using swab culture, pus culture, then on fifth day or seventh day will send blood culture also, and after 10 days, if these symptoms are not in decreasing trend, then we'll go for urine culture also, then change catheter and catheter tip culture we send, central line tip culture we send also.
Okay, so you mean to say कि after seeing the symptoms, you send the culture report, maybe of the any of the biological fluid. So I would like to know over here, when you are sending the culture reports, so do you wait for culture test results or you start your antibiotics as per your vision and the experience?
No, actually, in our setup, culture reports sometimes get we start empirical therapy. So most of time we, on the basis of symptom, we started broad spectrum antibiotic initially. Then we follow the trend. We wait for the culture report also to start the correct antibiotic according to resistance and all. And if symptoms subsided, we taper the antibiotics. If symptom are worse, then we are trying to add some more antibiotic. We uh, we are getting.
You mean to say कि you know patient is suffering from the infection and you send their sample,
Yeah.
but still you provide them antibiotics as per your expertise without seeing results. And on the basis of results which you will get maybe after 3 days, 5 days, or 7 days, you may sometimes taper the dose, or sometimes if condition get worse, you may change the treatment. It is the routine practice which most of the
Yes.
physicians
Yes.
follow. So
Yes.
here the most important thing, because of this practice, doctors or the patient basically develop the antimicrobial resistance. So what is your opinion? Like the train what you follow, we follow, and most of the world follow, they do send a sample, and as you told us that you start antibiotics, empirical antibiotics without seeing the results, and you can change taper the dose after seeing the results. So what do you think, if you get the results within 1.5 hour, what do you prefer? You still use your expertise or opinion, or you would try to give a result, the treatment on the basis of the results? Like अगर आपको 90 मिनट में रिजल्ट मिलता है, तो आप उसके बेसिस पे पेशेंट को दवा देना चाहेंगे एंटीबायोटिक्स कोर्स?
Definitely broad spectrum. Definitely, in our practice, we usually start broad spectrum or anti empirical therapy because we doesn't have exact antimicrobial resistant pattern actually. We got usually in most of setups in India, usually we got after minimum 48 hour requires. Okay, so if we got these results in within 90 minutes, this is really wonderful things uh, which we obtain, and this is beneficial.
You are saying कि if you are getting the results in 90 minutes, so rather than giving the empirical, you would prefer to give the test based antibiotics to the patients. What is your opinion? What do you think, how it will be help patients versus doctor? Like people say ki if the test is within 90 minutes, maybe what is the cost of antibiotics what patients are taking in those 5 days time, when you are not knowing, जब आपको पता ही नहीं है कि uh, what is the actually infection, but you are giving the antibiotics as of your expertise. So what is the load and the financial load to the patient when they are actually getting these treatment in any setup? So what is your opinion about that?
Get result in within 1 hour or 2 hour like this. So on the basis of symptom or basis of sepsis load for patient initially land up with infection, then it goes to sepsis, then goes to MODS, then goes to multiple organ failure also. Okay, break this cascade. So we empirically thought there is gram positive, gram negative, and some other broad spectrum, whatever the causative isn't. The major infection by gram positive and negative, it covers the mostly. But it also causing also because if drug has some resistant and it has side effect, it's get worsened effect. Okay, so if we get result within time, so start correct antibiotics, it will be definitely beneficial for patient and also for doctor also. Yeah. So we will break the cascade of this infectious vicious cycle.
Oh,
Okay, we can prevent from sepsis to MODS. We break, so patient can usually discharge within time, and the cost effectiveness also. bed early discharge will also low cost burden to the patient.
Ultimately, it is going to be a beneficial situation for the patient versus
Yeah,
doctor. They can get early discharge, they
definitely.
can get treatment in time and the correct treatment. And doctors get the
Yes,
satisfaction, obviously, if the patient are getting treatment within time and getting fast recovery. Yeah. So, what is
right.
your protocol and opinion about your infection treatment during the burn cases, which you are expertise in?
Lot of burn patient in our area. We are running the level 1 burn center in nearby districts. It's cover around 20 to 50 lakhs population. Near 4 to 5 district all also attached. This is the referral center. So our protocol is when the patient land up with in our department or our ward, initially we start with calculating the burn percentage area and start resuscitation, ABC, airway breathing and circulation, everything according to protocol, ALTS protocol. Then after that, we start, first 40-hour critical for there is the need for antibiotic, start antibiotic to prevent further infection or further sepsis. It's depend upon total body surface area, how what is the total body surface area of the patient and what is the weight of patient and all. Okay, so after this, on fifth day, we send pus culture with these wound swabs, and on seventh day, we usually send blood culture also to check what we start antibiotic on second day. This is correct or not. And after that, we getting the results of blood culture, pus culture, and all. We give antibiotic according to them.
I would like to know how important is treat this antimicrobial resistance with the golden period. Matlab, as of your patients are also burn patients, are very sick patients. So what is that golden period? Like, for example, you are treating them even in the fourth day when sepsis is going to develop, and you are still giving them antibiotics as of the proper set protocol, the gram positive, gram negative, and the antifungal. What is your opinion if this golden period, if you get something in 90 minutes, how it will change your patient's prognosis and mortality rate?
Initial period 1 or 2 hour when patient land up with shock or sepsis and we start antibiotics. So according to literature, when we are not starting antibiotic in golden periods, it will lead 10 added 10% mortality every hour. So golden we are usually starts antibiotic in golden period. It will definitely improve patients' prognosis and outcome.
So you mean to say 10% every hour? It means around if we are delaying the treatment of antibiotics by 10 hours, it will be near about 100% patient's chances to
Yes, yes, yes. Patient goes to multiple organ failure after
multiple organ
sepsis.
failure.
Yes,
Yeah.
yeah.
Okay. That's a wonderful information because most of the time people don't understand the value of this golden period when these antibiotics to be prescribed in a precise manner.
Yes.
Okay. Patients do get uh, complicated with this delayed antibiotic treatment. If you are not they are not reaching you, or if you think we should delay and wait for the patient treatment, do you think the patient get do complicated?
Sometimes in some patient whose percentage is more and vital organs like according to burn phase, develop respiratory tract infection and all. So these patient can be worsened. So if we get correct information about correct antibiotic sensitivity, so we can improve these results with
So
ICU setting also. Yeah.
so it means because here I would like to tell to most of our audience is actually aware of our work and all. So we have developed a
Okay.
device which is which is called Prathama Sense Genosensor. It is world first paper-based genosensor, which can give you
Okay.
result of infection and your antimicrobial resistance, which you are actually a pain point, can get all the results in just 1.5 hour. So
Oh,
you do
great.
not
Wonderful.
need to.
Wonderful thing. Yeah. This is
So
beneficial for patient, hospital, doctor also. Yeah.
yeah, it is going to, I think, the value proposition towards the everybody's life who is involved in this healthcare overall system. So right
Yes,
now,
yes.
what we are having, the sepsis, the UTI, and the critical care patients like you are handling. So these kits are already available, and right now we are actually doing the pan India trial, where we are actually opening and discussing in all of our webinars that whoever is interested in doing these trials with us, we are right now in the consideration with the ICMR evaluation. So later or sooner you will find that it will be under guidelines by the government of India. So we are in the trial part right now. We are looking forward the partners who are interested in doing the trial with us in this early time, so that we can give the more robustness towards the technology, towards the healthcare. So it will help the people not leave. People should not just leave lost their life because of infection. It is a really really very critical thing to be deal with. What is your opinion? I feel that infection is not treating in such a serious manner. It is literally taking care in a very casual manner. What is your opinion?
We get those devices in our institute, in our setup, or in clinical practice, really it's a miracle to the patient. Actually, the ICU burden, the hospital burden, definitely 20, 30 patients will ultimately go critical because of those infections. And within golden period or within time, if patient oriented, so definitely it will be wonderful thing. Yeah, really it will be helpful.
Yeah, here Dr. Raghavan can give some light on ICU patients. What is his opinion? Dr. Raghavan is there?
Hour, we have to some give the patient antibiotic, and we need to start resuscitation early, and then after that early detection, any mean by culture or any molecular detection technique, or by plasma sense, any detections can be done, and time we know, earliest we know which infection is there and which antimicrobial resistant pattern is present in the body, we can change the antibiotic accordingly. And we already seen that after using the rapid detection devices, rapid detection technique in patient, very fruitful to the patient and their outcomes, and which decrease mortality significantly.
To tell about one by one to the audience that actually in the daily basis, also in the routine life, how they should use the antibiotics, because people are not aware and people are using antibiotics left and right. We are following the guidelines which are international. I would like to I would like to ask you, both of you, just tell the audience how they should use the antibiotics in their daily basis.
Antibiotics very judiciously, and we not go for the antibiotic with the over the counter, taking the antibiotic by the over the counter, any other over the counter drug. We use antibiotic when the patient having diagnosed case of any bacterial infection, and the patient who having generally only having fever is not mean for that patient is having bacterial infection. There are many other causes of the fever, non-infectious causes of fever also there. So we have to know that what is the cause of the fever. Antibiotics only not going to help the patient to recover by the non-infective causes of the fever. So that's why we have to know, we have to diagnose first what is the cause of the fever. Then only we have to give the antibiotic. Antibiotic should be given in the proper doses, proper route, and to should be cover the proper duration. Under duration, over duration, both can be harmful, which can lead to emergence of the antimicrobial resistance. And AMR is the going to be more further in future. There may be high chances this antimicrobial resistance will be the one of the largest cause of the mortality in the patients. If are not easy, newer antibiotics takes long time, long research, and very tedious. And the companies are not very keen to produce newer antibiotics because it takes more than 10 years to produce an antibiotic, and resistance to develop resistance it a high takes high, it takes very low time, very low exposure to patient if we are not using antibiotic appropriately.
Very good information according to patient and audience. And the most important thing is judicial use of antibiotics according to proper susceptibility, sensitivity, and duration is very important. And early start is also very important to prevent further consequences. Yes.
Again, and all of our audience who's wonderful and patiently